Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, we have a different guest from the hospital and we talk about different healthcare issues, services, and programs that we provide. I think this program will be of interest to you and your family, so stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Adam Braze. Thank you so much for being on the program today, Dr. Braze.
Thank you for having me.
Welcome to Kingman. You're one of our newest physicians here at KRMC, and you're a thoracic surgeon, right?
Yes.
Now, let's explain at the very top of the hour, before we go too much further, what is a thoracic surgeon? How is that different than other surgeons?
Thoracic surgeon specializes in the treatment of organs in the chest. So the
just
heart,
the chest? So
mainly the chest.
Okay.
The heart, the lungs, the esophagus.
All those important things.
Yes.
That's great. And now you partner quite a bit with some of our other physicians here as well, right? You work with like Dr. Porter, not sure who else you're working with right now, I'm sorry.
Yes, thoracic surgery deals with some very significant disorders, such as in regards to those organs. So cancers of the lung and cancers of the esophagus. So there's a multidisciplinary approach to the treatment of those, and that requires interaction between me, the pulmonologists, the oncologists, the radiation oncologists, cardiologists, and the radiologists.
So is cancer the main villain that you deal with when you're doing your surgeries?
Cancer is the main villain, which I'm dealing with.
So unfortunately, I think you probably see a lot of that right now in Kingman. I know we're working on trying to find some ways to hopefully someday in the future have some ways of improving our stats. But I know, number one, first of all, our smokers are 35% of our population right now, which is really high. And speaking of which, what other types of issues besides cancer do you see that you deal with?
Common to this area would be complications of coccidiomycosis.
Which is?
It's a infection of the lungs that's very common in the desert area.
Like valley fever type of thing?
Exactly.
Oh,
exactly.
Okay, I've heard of that.
Yes.
And I know that we do have a lot of that, unfortunately, in the desert too.
I'm sorry.
Go ahead.
Oftentimes it doesn't require surgery, but there are a handful of times where complications of the infection requires surgical intervention.
So when you do the surgery for that, do you actually have to go in and remove parts of the lung? Are you scraping and cleaning? I have no idea. What would you be doing?
Sometimes after the infection, there's a large cystic lesion that remains, which is a setup for recurrent infections from other pathogens, bacteria, typical pneumonias and things, and those sometimes have to be removed. Otherwise, it can also cause an infection between the lungs and the chest cavity, and that does have to be scraped out, just as you said. Yes.
Sorry, I get kind of layman sometimes. But now, so how much of your lung can you live without?
A healthy person,
right?
Believe it or not, can live with only their left lung, which is 45% of your total lung volume.
The right lung is 55%?
Yep.
I did not know that one was bigger than the other.
Slightly.
Okay, yeah, that's 10% can make a difference.
Right.
What makes that difference? And is it all right lungs are bigger than the left?
Yes, because of the heart structure is on the left side, so the left lung tends to be a little smaller.
Oh, never would have thought of that, but it makes sense. As soon as you said that, I went, oh, yeah, not enough room in there.
So in this area, we have a lot of COPD,
Yes.
and which is damage to the lungs. most common cause is smoking. And in patients that have progressed to need oxygen, they have destroyed that extra reserve that we all have. The reason we have that reserve is so you can walk comfortably and then have the reserve to run. So obviously if you now are on oxygen, when you're at rest, you don't have that reserve to run or be active.
So your surgeries, how does that help? What do we?
It interferes. To do lung surgery, I need a little extra lung. The patient needs a little extra lung reserve for me to remove some lung.
Sure, because that makes sense too, because you're going to take away, so if they don't have any extra, then they're going to be short.
Correct.
Right?
Correct.
And so when that happens, I mean, if they're on oxygen, does that continue then to be able, it's like a life support, right?
Correct.
Yeah.
Generally, we're not able to remove lungs or parts of lungs in patients that are already on a significant amount of oxygen.
Oh, okay. So you get to that point where there's not too much that they can do
Right.
about that. And then the same with cancer, now you're seeing, and esophagus also, that's this part, down the throat, right, in the voice box too?
The esophagus starts just after the voice box and connects the mouth, essentially below the voice box, to the stomach.
Okay.
So it's the tube from about here to about here.
Okay. And so that's another part that you specialize in, and is that cancer as well usually, or what other things?
Cancer is one, and also non-cancerous disorders of the esophagus, bad reflux, there's treatments for that. Also, we can get, just like anywhere else, diverticulums or hernias of the esophagus, those can be treated. And some motility issues with the esophagus when it doesn't squeeze right, sometimes it requires surgery.
Okay, so you can like help it tighten itself back up
Help
again?
it relax.
Oh, okay.
Help it relax.
So, and I know that like with acid reflux, as acid makes it's the same thing, so it can eat away at the esophagus, right?
Yes.
So
and
then
that
you can go in.
And that can be a setup for cancer down the road. Prolonged
Again,
reflux can be a cause of cancer at the junction between the stomach and the esophagus.
Okay, so when people have acid reflux, they need to be proactive with dealing with it, right? Not just let it go. I mean, I think a lot of times, oh, I've got heartburn, but if it's a chronic problem ongoing, they should make sure
It
they
can
get that
lead
look.
to that.
Yeah, so long term would be good to look at it. So there's a wide variety of things that you are specializing in, obviously, here. What kind of training did you have to get, and how did you decide to become a thoracic surgeon versus some other kind of surgeon?
I think, well, first I had to do undergrad.
And where was that? I'm sorry.
At Fresno State
in California. Okay.
And then from there, I always wanted to be a physician, so that was a no-brainer. And then I went to medical school in Vallejo, California at Touro University, and decided fairly on that I wanted to do things with my hands.
Okay, so the surgeon.
The surgical interventions or interventional type fields appealed to me. So I just decided on surgery. And then I went to general surgery training, did 5 years of general surgery training in Michigan. And while I was in my training, wasn't sure if that's exactly what I wanted to do for the rest of my life. And I explored other options, one of which was radiology. As a general surgery resident, you get good at reading radiology.
Right,
so it seemed,
and it is pretty cool what
like
they're
a
able to
natural
do.
change, but you get out of the proceduralist realm unless you go into interventional radiology. And then one of my mentors, and now very close friends, who was a cardiothoracic surgeon, I did a rotation with him and found a new passion when I was in general surgery. So then I went to Rush University Medical Center in Chicago and did a 2-year fellowship in cardiothoracic surgery.
Excellent. Now, somewhere along the line there, too, I believe you met your wife, right?
My wife, yes, we met in medical school.
Okay, very
Yes.
good. And for our audience, because Bernadette has not been on the program yet, but she's our newest ENT, ear,
Correct.
nose, and throat specialist. And we're so excited and blessed to have both of you here. That's just like two for, well, not two for the price of one, really, but we've got two physicians with one fell swoop, if you would. So that's we're double blessing for us. So we'll have to get Bernadette on here one of these days when her schedule slows down a little bit. She's been as crazy as you, I think, for being busy. So when you did that special training and became the thoracic surgeon, then where did you go from school?
After that, I made a significant career choice in that I wasn't sure if I wanted to do just cardiac surgery or just the lung surgery, as in some institutions those are divergent, although it's the same training. And I chose a job starting a new thoracic program with no cardiac surgery in Pennsylvania.
Okay.
And I was there for 3 years. And my wife and I are both from out west.
Okay.
And being in Pennsylvania for 3 years, and Chicago for 2, and Michigan for 5, we soon realized that we'd been away from home for a very long time.
Right.
And with our family now with 2 boys, we wanted to be closer to family.
That's great.
So it was a difficult decision because we had
Right.
both had good practices in Pennsylvania and had a good, patient-physician relationship and liked it. But we made the decision to come out west. And it just so happened that
We were
Kingman
looking.
decided to, it turned out to be a good fit for us.
That's awesome.
Smaller town to raise the boys, and seems like a very good place to practice
Good.
our
And you're still
specialties,
close to family.
and we're close enough to
right.
family.
And we have much better winters.
Much better winters, much better
Especially
winters,
after
yes.
this year.
Absolutely.
Oh my goodness, I think Pennsylvania's been as bad. I'm from Minnesota originally and still have family back there. And I swear, every day since Christmas, I was getting weather alerts on my phone from Minneapolis with either sub-below zero or blizzards. And I think it was going east, so Pennsylvania probably got it too.
Yes.
You have friends back there still that you can commiserate with?
Yeah, fellow colleagues.
Yes.
So
Send them texts of, oh gee, it's 75 and sunny in Kingman. Too bad, what's it there?
yes, we moved here in November, so we had the opportunity not to experience a snowflake this winter, and
Darn,
it
huh?
was great.
Well, and this has been an unusual winter even for Kingman to have been so nice, because I was going to say when your boys, if they want to build a snowman or have a snowball fight, you'll be able to take them up to the Wallapies some winters, because we actually do get snow up there that stays for a while. So it's, if they have snow withdrawal, or you and Bernadette have snow withdrawals, you can always drive up and play in the snow and then come back down. That's my idea of a perfect winter.
Absolutely.
So we'll get back, I'm sorry, I got off track there a little bit, but talking more about your practice. So right now I believe you're with Mojave Surgical Specialists. That's where your office is at, right?
Yes, that probably is going to be changing.
Okay.
I want to expand the thoracic surgery a little more and make it a more collaborative approach with the pulmonologists and work closer with them.
So
I
you probably
most
try to
likely
be closer to-
soon we'll be relocating to the professional building.
Great, that makes sense too. So you're right there with Dr. Matheny and Dr. Wynn.
Correct. And it serves the patients better too. Post-operative lung patients or any chest surgery patients generally need follow-up chest x-rays and
again-
follow-up pulmonary function tests, and some of them need pulmonary rehab, all of which are in the medical professional building and therefore would be better served if they were here. So it's
One stop.
one stop. Get your x-ray, come upstairs, come see me,
And then
we
go
look
over
at
to
it
see
together.
Dr. Matheny
And
if
go
you
over
needed
and see your
to. Right.
pulmonologist. Exactly.
That's going to be, I think, a good segue, or if you would, for it makes sense that that would
Absolutely
be
makes
all
sense.
together there. And you're closer to the hospital too.
Right.
Like, it's not like they're that far away. I always joke about when people talk about our long distances in Kingman. I'm like, really? Well, we're going to take a quick break, and when we come back, we'll talk a little bit more about patients and some recommendations you might have for people, so you don't have to see them as often, maybe. So I hope you'll stay tuned. We'll be back right after these messages.
After the 7th year of analysis, there was a 20% increase in survival.
Welcome back to Your Health Matters. My guest today is Dr. Adam Braze. Thanks again for being on the show, Dr. Braze. We were talking before the break about the different types of surgery that you specialize in. We talked about the esophagus and the lungs and the types of the diseases and issues that you see a lot of. You talked about cancer, COPD, is there and valley fever. We talked about that as well. Is there anything else like that that you're seeing or that you expect to see here?
Complications of COPD, you can have, patients can have collapsed lungs.
Oh.
And
that
can happen spontaneously.
Wow. So you're just like walking along and...
Sometimes, usually it's associated with a cold. They have a lot of coughing. They have maybe some bubbles on their lungs from their COPD.
Okay.
And those can rupture and you get collapsed lungs.
No, COPD, it's chronic obstructive pulmonary disease.
Correct.
And the symptoms that lead up to that, is it shortness of breath, coughing, what types of things?
Generally a chronic cough. Sometimes there's wheezing similar to asthma. There can be some type of reactive airway or spasm of the airway associated with it. But really, shortness of breath with exertion would be the first sign. That's when you're going to notice it, because now your reserve of your lung starts to go away, and the first time you're going to note it is when you exert yourself.
Okay.
So, and obviously a more advanced person that's had it for a while can have shortness of breath just sitting in this chair.
Wow. So if a person starts having those type of symptoms, the shortness of breath, the first thing would probably be to go to see a pulmonologist, right?
They're a pulmonologist if they already have one, or their primary doctor, which
would
can refer them to a pulmonologist.
Okay. And then at what point do you get involved?
In COPD, generally only with complications of it, such as a collapsed lung.
Okay.
And sometimes if a patient has giant bubbles, or some of those can be removed.
Okay.
So.
And fluid buildup? You know, we talked during the break, but that the lung has minute amount of fluid, so big amounts are not good.
Big amounts are not good, and many things can cause that. Anything from heart failure to kidney failure to cancer can cause fluid buildup. Poor nutrition, an illness or a pneumonia can cause fluid to build up. Many things can cause fluid to build up, and part of treating that appropriately is figuring out what's the cause, first of all.
Sure, because then all you're doing, getting rid of the fluid, it'll come right back if you haven't figured out what the problem was.
So most of the time we need to drain it, and the analysis of the fluid can give us a lot of guidance as to what is going on.
So when you drain that, how do you drain a lung? It's not like you can go to the gas station and pull the plug, right?
No. Many times we have the radiologists do it. They use ultrasound. They find a space where the lung is away from the chest wall, pushed away from the fluid, and passing a hollow needle through the chest cavity into the space between the chest cavity and the lung, and drain the fluid and send it off to our pathologist to analyze.
Okay. Now, when you're doing your surgeries, when you're actually working on the lungs and the esophagus, are you having to like open up the chest, or how do you get to that? Because our ribs and sternum and all that protect it, right, and cover it.
Correct. The common approach to treating a surgical intervention on someone's chest of the lungs and the esophagus is through the sides, through the rib spaces.
Okay.
The goal is to really try to do minimally invasive approaches. Our rib spaces are supposed to be about that big. In a traditional open thoracotomy, as we call it, or an open chest case, we have to crank that open enough to get my hand in.
I was just going to say,
so we use, the vice crank and open it up.
Okay.
That's a traditional thoracotomy. Lots of pain, lots of slow recovery, long recovery.
Because of we all know whenever you bruise or break a rib, that takes a long time. So basically that's what you're doing is bruising, right, as you're stretching them?
You're moving bones in ways that weren't designed to move. But in minimally invasive lung surgery, for instance, we've come a long way, and just like minimally invasive surgery for the belly or abdomen, where you use a TV camera, we do the same thing, and our TV cameras are about, you know, a little less than a half an inch thick, and can go in between the rib spaces.
Amazing.
And we can have the anesthesiologist collapse that lung that we're working on so that there's space, and couple access incisions in between the rib spaces is all that's needed to remove a lung or remove a mass and pull it out through that rib space. So lung surgery can be done without spreading any ribs. There's still post-operative pain, but the recovery time is shortened to 2 weeks versus 6 to 8 weeks. And with open cases, there's the known syndrome of post-thoracotomy syndrome or chronic pain from that incision. So you get away from that.
That's amazing, and that's awesome. I'm sure your patients like that a lot better too.
Right, so that type of surgery is ideal when we find early lung cancers.
Okay, and that's a good thing, a good segue there to talk about detection early of lung cancer, because again, we were kind of talking during the break that once a person starts having the symptoms, it's not that it's too late that we can't help them, but the cancer's already there.
Correct.
So what can we do to help early detection?
Well, let's say a few things first. The most common stage of a lung cancer that we discover, the most common stage at which lung cancer is when we discover it in a patient, is a stage 3.
Oh, wow.
Stage 3
that's pretty far advanced already.
Correct, and that has a survival of 5 years, somewhere around 30 to 40%. So pretty low.
Oh, wow.
So pretty dismal.
Yeah.
And right now, the only screening that's paid for by insurance companies would be an annual chest X-ray with your physical exam that you get yearly at your after the age of 50 or 55.
Right, yeah.
Only 15% of the lung cancers seen on chest X-rays are able to be treated by surgery because they're so advanced.
Oh,
so clearly not a good screening tool.
No.
So in 2010, thoracic surgeons, pulmonologists have known this for years, that a CAT scan can find a cancer early, much earlier.
Okay.
So in 2010, the National Lung Screening Trial was undertaken, and over 50,000 people were placed in this study, in which yearly chest X-rays were compared to yearly low-dose scans. Low-dose scans are equivalent to about 15 X-rays in radiation exposure versus a diagnostic CAT scan, which is about 100 X-rays.
Okay.
Just to give
the difference,
comparison.
Yeah, because people are concerned sometimes there
about
is too much radiation, right? Yeah.
And they did that time 0, year 1, and year 2, and then followed those people yearly. And the study was ended early because they found out after the 7th year of analysis that there was a 20% increase in survival from lung scans in discovering cancer early, and an overall 7% survival of all diseases that you incidentally discover.
Oh, so they're looking at the lungs, and then, oh, by the way, while we're there.
7% overall increase in survival and a 20% increase in disease-specific survival of lung cancer. So the study was abruptly stopped because the endpoint was clearly reached, that it's a no-brainer.
Right,
if we were to scan with low-dose scans all patients that are high risk for lung cancer, which in the study was anyone over 55, between the age of 55 and 74, that smoked at least 30 years.
Okay.
That was the criteria of that study.
Okay.
So if we were to scan those patients, we could improve their survival. And the goal would then be to stage shift the presentation of lung cancer. So what could we do if we stage shift from the most common stage being stage 3 to a stage 1? Well, stage 1 lung cancer, the treatment is primarily surgery. You don't need chemotherapy, you don't need radiation, followed by surgery. Just go in and
remove that part.
It's surgical resection, and the disease, the 5-year survival is as high as 90%.
That's a huge difference.
So 90% versus 30% if we were to
Right.
scan the individuals that are considered high risk for lung cancer.
Okay.
Part of the Affordable Care Act says that in 2015, January 1st, Medicare and all private payers have to pay for lung cancer screening.
Well, that's a good something to look
I don't know
forward
what that
to.
means.
We can hope.
Are they going to really pay yearly for scans? Every other year? I don't know. But that's what's been said in the Affordable Care Act.
I think we're going to have you back on the program. We've already run out of time, but that's something I think that's going to be a vital interest to our community. So we'll be back. Thank you for joining us today, and stay tuned. We'll have another great guest on the program next week.